And I am with Dr. George Kimathi from Amref Health Africa, who I would love to just hand over the mic to. Dr. George, could you tell us a little bit about yourself and what you're looking forward to in our discussion today?
Oh, thank you. Thank you so much, Vince, and good morning, everyone. Very delighted to be here and to co-host you with Vince. My name is George Kimathi. I'm the Director Institute of Capacity Development at Amref Health Africa. I'm based in Nairobi. I've also been involved with the Finish Medial for quite some time now, and the order finish, perhaps close to 10 years. So exciting to be part of this conversation today. I'm expecting, Vince, I'm expecting a very, very interactive session for the next few minutes. I'm expecting us to get a chance to hear insights from our colleagues from Africa, our colleagues from India, on the opportunities that are there that can link business with sanitation and curative health. I think that's really powerful. And I'm particularly excited to listen to what India is doing to leverage on technology and digital tools to do telemedicine, and lots of work also that is happening in Africa, because Africa, there is so much in Africa in terms of sanitation. When you look at the need across the sub-Saharan Africa, when you look at the young population that is there, when you look at the fact that 7 of the fastest growing economies are in Africa. And therefore, when you match the need and the growing economies and the huge young population that is looking for employment and livelihood opportunities, I can't wait to listen to the conversation today, VC. So this is really exciting for me. But also thoughts on where we should go, what is happening currently, but also where we should go in terms of expanding the business and entrepreneurial space within the sanitation value chain. That's really important. But also I think exciting is the fact that today we also have a colleague of ours, Jimmy Patch, who is sketching, who is doing a graphic on the conversation that is going to happen. So it's not only going to be verbal, it's not only going to be audio to be verbal, it's also going to be sketched by an artist colleague of ours who is doing that. And once in a while, we're going back to Vince, Jimmy, just to check what is capturing from our conversations. Jimmy, I'm not sure whether you can hear us and whether you can wave. We want to see whether you are still there. Hi, Jimmy.
Hi, I am still here. Thank you, George. Yeah, I'm just going to share up what I've been working on. It's not much yet, but this will build up over time, and you'll get to see the kind of work that I'll be doing over the session. So I look forward to capturing everyone's thoughts.
Perfect. Thank you, Jimmy. We'll be back to you soon. So over to you, Vincey.
Thank you, Dr. George. Hi, Jimmy. Really exciting setup that we have. And just to reiterate what Dr. George mentioned earlier, we want this session to be as interactive as possible. So feel free. We have a separate technology where you can actually send in any kind of inputs, comments, questions that you have. Please also note that the Zoom chat is disabled for right now. But we do have a Pathable, if I'm right, technology where you can actually send in your comments and questions there. But yes, feel free to just share if you have any interesting insights. And I'm really happy just to understand more from all of our different speakers and panelists, more on how we can link both sanitation and healthcare in a very strong way. As a young professional, as well as a professional who's working in the intersection of development and water, I think one of the key things that we're going to be discussing and unpacking today is how there is business opportunities related to WASH in the sector that we must kind of really explore together. And from my own experience as well, I can give you 2 very excellent examples in India, and I'm pretty sure some of you may know them. One of the great business opportunity, it was a model that was actually started by a young woman herself. She started this foundation called Mahina Mahila Foundation. which works in providing livelihoods for women from low-income communities. And essentially, they're focused on menstrual hygiene and how they can make biodegradable pads, which are both low cost, but also generate livelihoods for the women in that community. I think that's a really strong business aspect to it, which just gives us kind of a context of how there is a strong social and economic return that can come out when we link these two aspects together. Another great example that comes to my mind is another company called CareNext India. They are a technology platform which really uses digital technology. It also ensures that maternal health is taken care of by reaching women in rural communities as well as low-income communities in urban areas with the kind of medicine and the medical expertise that they need at the doorstep itself. This just goes to show that there is so much that's there possible in the sector if we really link these two aspects together. And we do need to make sure that there is a business aspect to this. There is a strong return on investment as we dig deeper into this aspect. I'm just going to also quickly ask Dr. George, have you ever seen sanitation and the health-making economy, how, making economic sense for both national and local governments? Could you just give us a little bit of examples from your, from your end and from your learning as well?
Yeah, thank you. Thank you so much, Vinci, and thank you so much for those wonderful examples that you've shared. Absolutely, I've seen. I think in my experience now, I see, and COVID has actually made it even clearer to all of us that actually health and the economy are intertwined. They are very symbiotic. So when you improve the health of populations, the economy largely will grow. When the economy is good, the health of population is good. But then the challenge that we see, particularly with developing countries, is that sanitation plays a key role in the health of communities. And you see that across the globe, 10% of healthcare costs actually are due to poor sanitation. If we get to details and we narrow down, we zoom into, say, India and Africa, over 50% actually of the elements of the diseases that you'll find in most of the communities are due to poor sanitation and hygiene. That's not acceptable. So, and when you look at basics, a third of hospital beds at any one time are actually occupied by people who are ill out of lack of access to, against sanitation and hygiene. But when you get to actual numbers now in terms of real cost, a few years ago, about 4 or 5 years, the World Bank did a study in Kenya and realized that actually Kenya loses every year $324 million. You can imagine what that would do to increase access to services. But then, in the context of our conversation for today, because we also try to understand where USC fits into sanitation and also delivering healthcare, only 10% of populations in most of Africa and India you find are actually covered through health insurance, which means then the most important pillar of universal health coverage, which is financial protection, is a big challenge to most of the communities that we target. And then the other link, Vince, is that in these communities, most of these populations, out-of-pocket expenditure takes about 60%. What that means is that if you have $1, 60% of $1 that you have goes to out-of-pocket expenditure for healthcare needs, which again is linked to lack of sanitation and proper hygiene, which again links to poor health, which is disastrous. As I said, technology has come and should help us actually to leapfrog, and we'll listen a little bit from India on what that is doing. But I see a lot of opportunities again with technology, and I've seen that before. Technology as an accelerator for us to be able to understand customer needs for the designs of sanitation products and services that require customer preferences, but also technology assisting us to do sanitation marketing. Technology assisting us using digital tools, of course, to also do market intelligence because of the data science that you're able to capture. Back to my other point that I shared, which is that when you look at, say, for instance, Sub-Saharan Africa, 60% of the population in Sub-Saharan Africa live in informal settlements. So, and Africa is the fastest urbanizing continent now. with a population increase of about 3% every year. So if you are looking at 60%, and if you are looking at potential sanitation businesses, and you are looking at populations that are living together in informal settlements, and they are struggling with access to improved sanitation, then and you look at the value chain from all the way from containment to storage to transportation to treatment to reuse, then Africa and India presents, and most of the developing populations presents a huge opportunity for sanitation enterprises because of those things. I think there are many untapped opportunities. I guess in my thinking is that we've actually only scratched the surface of sanitation businesses that are out here. Over to you, Vise.
Thank you, Dr. George. I think those were some really excellent points that you raised. You talked about financial inclusion. This is exactly why the session is so important, that we're actually unpacking what a business opportunity could look like and why finances can really be the hook over here. I think when I look, and since I have worked in the business side of things, it's one of the key basic things that everyone talks about is what is the return of investment over here? But there is an opportunity, as we clearly see, and Doctor, as you really have shared from the Africa and India example over here, on how we have this opportunity, this economy, the sanitation economy that can really drive a lot of business opportunity over here. And just on that quick note, I want to actually ask some of our case study experts we have on our panel to really highlight this link between health, sanitation, and business opportunities that we're seeing in the countries that Dr. George also spoke about. And I'm going to quickly invite Abhishek, who's from Finnish Society India, to kick us off and just share a case study that he and his team has been working on around telemedicine in India.
Vise, maybe before that, for us to take a small break, because I see the discussion is getting hot now. If it's okay for us to watch a Finnish model video for only a few minutes, if you allow, if that is okay. And you asked a fundamental question, Vise. What is the return on investing in sanitation? Actually, World Bank has shown that if you invest $1, you get a return of $5 if you do that in sanitation. But let's see what Finnish model is doing. Over to you, Lolen.
Thank you.
Finnish Mondial is a partnership between Waste, AMREF and Aqua for All, and stands for Financial Inclusion, Improved Sanitation and Health. It's a programme working towards safe sanitation for all and is implemented in India, Kenya, Uganda, Ethiopia, Tanzania and Bangladesh. Finnish Mondial ensures people are aware of the need of a safe and durable toilet. They want to buy one, can afford it, and local people can build them. But what does this mean? Women like Anna from Kenya and girls like Juhi from India have a healthy and safe life and can develop themselves. They can work and go to school as they no longer get ill because of water-related diseases. Because of the Finnish programme, sanitation marketeers like Emmy from Tanzania feel they are doing something for their community as they tell people about the importance of a safe and durable toilet, which trained masons like Manu from Ethiopia can build. They now run a successful sanitation business. And farmers like Abdul from Bangladesh use the fecal sludge from the newly built toilets as co-compost for crop production. Therefore, communities are healthier and have climate-resilient food. Finally, financiers like Mr. George from Uganda supply sanitation credit, and local governors like Miss Gamutu from Kenya stimulate sanitation market growth and awareness. By applying a multi-stakeholder approach, the Finnish programme involves the entire sanitation value chain. Over 5.6 million people enjoy the benefits of safe sanitation thanks to the programme. This is only the beginning. Let's create a global sanitation revolution together.
Amazing. I don't know about the rest of you, but that is such an empowering video itself. Just goes to show that there is a clear... I'm going to quickly hand it over to Abhishek. I think, Abhishek, this video was such an excellent introduction to the program itself, but over to you to know more what you're doing in India.
Yeah. Hello, am I audible and visible to all?
Yes, Abhishek, please go ahead.
Yeah. So thank you so much for this opportunity. And namaste, all of you from India. And I'm Abhishek Chaudhary, and I'm a part of this Finnish Mondial project. And in India, we are working to establish a linkage on sanitation and health. We have started a pilot project here in India in the state of Odisha. In Odisha, we have started this pilot project in the year 2009, where we basically want to establish a linkage between sanitation, primary health, and link it with insurance. So you'll see that we do not have good products, health insurance products in primary health. So the basic objective of this pilot is to see whether how the health status of an area is linked to the sanitation status of that. So I mean to say, like, if the sanitation status is good, then you'll see that automatically the diseases which happen over sanitation or like waterborne diseases, they come down. So we want to establish this linkage. So here what we have done is that we are doing teleconsultation. So an area of 34 gram panchayats has been identified, which basically covers around 40,000 odd population. And we have done a baseline of this population, covering their sanitation status and their drinking water quality status. And now what we are doing is that we are providing them teleconsultation, where we also get the data of the diseases which mainly occur in these areas. So this will help us establish a linkage between the sanitation status and the health status. So the project is like we have identified some rural entrepreneurs. These are the local youth that area whom we have trained, and we have provided them with a tab and a set of equipments. So these equipments are basically stethoscopes and blood pressure checking machine, a small ECG machine. So these are the part of that equipments they have. And now there is a doctor who's in a remote, maybe an urban center somewhere. And these rural entrepreneurs, they visit the patient and they provide them doorstep service, from where they conduct a video conferencing with the doctor who is sitting somewhere in India. And from there, like, the video consultation is done, and through these equipments, they can provide the readings to the doctor. And according to those readings and the symptoms, the doctor then prescribes the further course of action of medicines. So the objective is basically to not only to provide some data for the insurance companies to be enabled to design like a good product for the primary health, but also to generate an additional source of income for these people living in the area. So this is the basic objective of our pilot, and till date we have done more than 1,000 consultations, because needless to say, due to the challenges of COVID, so we got a little bit disturbed because of these pandemic. So, but still we could manage to do more than 1,000 consultations till date. And we are also planning, like, going forward, we are also planning to link it with lab tests and medicines as well. Because consultations alone, like, there is something missing. The lab tests are also an very integral part of this. So we are going to link it to pathological tests, which will be like, then again, appointment will be given online, and a person will be collecting the samples from their doorsteps. And we are also planning to take this project forward to the different CSRs in the country, And we are also trying to link it with the microfinance companies in the country who are having their different offices at various locations. So we are planning to tie up with them so that we have our different centers at their offices, and likewise we'll like to expand our area of operation and the impact. So that is the small initiative we are doing here in India, and I would request your well wishes and blessings for successfully. Thank you. Namaskar.
Thank you, Abhishek, for that really strong case studies. I think my personal takeaways from that is it's a great example of not just a model that is covering telemedicine, but I also see this playing a very strong role in terms of skilling of the people who are involved in the process as well. Because when we are involving the rural entrepreneurs, there is that aspect that comes through too. So thank you, Abhishek, for really sharing that. Dr. George, do you have any quick reactions or thoughts on what he just spoke about?
No, Vise, I think this is it. This is a future of what we do. This is a future of sanitation. This is a future of health, access to health, linking sanitation to telemedicine. And we've seen it now with the COVID that actually it's possible to do so many things without necessarily having person-to-person contact. So I like this. And looking at the population that this initiative is being done, that is India, then the promise is huge, really huge.
Yeah. Absolutely. Thank you for that. I'm also going to now invite Martin Muchangi. He's the regional WASH coordinator from AMREF Health Africa to just talk about the Africa example from Kenya and Uganda on how they're linking universal health coverage and safe sanitation there.
Hello, my name is Dennis Munai. I'll be speaking on behalf of Martin. So as the screen is pulling up, just to mention that the UHC agenda is a government-led initiative in the country, in Kenya, led especially by a government directive by the president. It's a president initiative to ensure that everyone has access to universal health coverage by the year 2030. So at the moment, there is a big campaign just to ensure that everybody rolls out, UHC is rolled out to everyone in the country. At the moment, 50% of the Kenyans are covered by what we call the National Health Insurance Fund. Of this, about $330 million is spent annually by Kenyans on healthcare. And the projection is that by the year 2022, we'll be spending over 1 billion through the National Health Insurance Fund. There is a campaign right now to change that from the National Health Insurance Fund to the National Hospital Insurance Fund. No, from the National Health Insurance Fund from the National Hospital Insurance Fund to the National Health Insurance Fund, just to cover the whole aspect around health versus the hospital. At the moment, there is a very, very little investment towards sanitation, while we know that sanitation is highly linked to the health status of communities. Through the diamond, we have 4 arms of the diamond. So we have the consumer, we have the financiers, we have the businesses, and finally we have the government. And with the diamond model, we cut across the 4 arms, and we think that we theorize that if we intervene, especially at the 4 arms, then the health status of the sanitation status of the communities will improve, and therefore, once we have improved sanitation, then we'll have reduced costs and therefore quality universal health coverage. I'll talk about how we look at financial protection, and this is basically we know that so many people go to hospitals because they have diarrhea. There's quite a lot of investment that we lose because of stunting due to sanitation, and especially right now where we have COVID, and the COVID is basically a matter of an hygiene aspect. So we theorize that if there is improved sanitation and hygiene, then household will save, and therefore more income for the national, therefore more income. And basically we try to talk to communities and households to make sure that one, they improve their sanitation status, and they improve their health hygiene status, and therefore make some savings. And these savings can be invested either to the National Health Insurance Fund or to their other needs. I was already talked about infectious diseases, for example, like COVID-19 at the moment, and therefore, and of course, diarrhea and pneumonia. These are infectious diseases that can be prevented because of improved sanitation and hygiene. And the biggest aspect, again, is through savings, capital expenditures. So basically, if there's improved sanitation and there's improved hygiene, then you'll have reduced government expenditure on curative health. All this, we theorize that, and we believe that we'll have a shared goal, that every citizen will have access to quality healthcare, again, without financial difficulties. And we also believe that sanitation and hygiene must be improved for quality UHC. So that's all. Thank you.
Thank you so much, Dennis, for that. This is such a unique model, and I really like how the focus of this case study was all about not just health coverage, but also using the financial aspect over there to get to that place. I know that we've had now a bit of technical, conversations right now. I'm just wondering from, firstly, the audience, does anyone have any questions? Feel free to leave it on chat. And then if we don't, we can definitely go to Jimmy or Carolina. I see that you introduced yourself.
Yes, thank you, Vinci. We do have some questions from the audience. I'm just going to read one and let's see how that goes. It's from Walter Nietke. And the question says, thank you for these statistics on sanitation challenges and outcomes in informal settlements, Dr. Kimathi. One question I always struggle to answer is how basic sanitation coverage in urban informal settlements affects health outcomes or healthcare spend. Is this relationship linear? What is the minimum level of coverage to significantly affect health outcomes?
Thank you, Carolina. Go ahead, please.
Thank you. Thank you so much, Carolina, and thank you, a colleague who has asked that question. I am tempted to suggest that we push it to the panel so that they can dive deeper. And if we have Agila, who is working very well in slum in Kampala, I know Agila would be more than happy to respond to that. But very good question. In terms of how much coverage you need to do, is the relationship linear or much more complex than just linear? Very, very useful questions there. But I would push it to the panel so that we have more engagement at that point. If that is okay, Carolina?
That's perfect. I will just save some of the questions for the panel then.
Yes. Okay. Okay. Should we go to Jimmy? Jimmy, can you ask? I know Vincent, you asked that we go to Jimmy.
Yeah.
Oh, Jimmy. Oh, thank you. Thank you, Jimmy. You're on the screen already. Thank you. This is wonderful. Within a very short time, you've already given us some wonderful insights here that are coming to the floor. Okay, our expectations I see here on hygiene and sanitation, and our call needs to be improved or needs to be improved. And the link, of course, between sanitation and health. And back to the question that our colleague is asking: is the relationship linear, or it's it's much more complex? Wonderful question. But this is where we are. Where do we go from here? I like this. We are at crossroads, and we have to determine how we need to move forward. It's about linking aspects together. Oh yes, it's much more complex. So we need to link many aspects together. Universal health coverage, use of digital tools, the losses that we are hearing from Kenya annually, 324 million. That's a lot of, that's huge resources that could be used to do other stuff. And of course, a call to action here, let's create a global sanitation revolution. Because I guess, as Dennis said, we cannot talk universal health coverage without talking sanitation. We cannot talk about leaving no one behind if actually 60% of our population in developing world have no access to improved sanitation. Then the call for leaving no one behind, it's just, will just remain that. I think that's what we are saying. And of course, the link here with the sanitation diseases, technology, big driver, big pivot that we should leverage on to do financial inclusion and much more. Diagnosis here. Oh yeah, and then back to your question. Exactly how is sanitation status linked to health? And then is it a direct linkage? Does it have other multiple variables that come into play? And can we have more discussion on that? Jimmy, thank you so much. This is wonderful. And I guess Carolina will also share this with our participants at some point later, because this makes it much easier for us to see what we are discussing. Okay, thank you.
Absolutely, Dr. George.
Super. Vince, over to you.
Thank you, Dr. George, for summarizing that. Thank you, Jimmy. Now we are going into a very exciting panel session. I just want to remind all of our panelists that our time is really short. So it would be great just to hear top-notch insights from you. We have a bunch of questions, maybe just to get started with. I'm actually going to hand it back to George, Dr. George, to just give us a quick, to start us with our first speaker. I believe, Dr. George, we are going to be hearing from Dr. Avinash Patajoshi. He is a doctor leading teleconsultation processes at SLN Medical College and Hospital in Odisha. Dr. George, I know you have a bunch of questions prepared for him. So
yeah, many questions, Vitsi, for Dr. Avinash. But Avinash, I'll ask you just one question because of, in the interest of time. Please, could you share with us? Everybody is pushing for telemedicine across the globe, and particularly for the most underserved in developed countries. But could you share with us your experience shifting from in-person consultations to online consultations? What are the ups? What are the misses? What are the wins? What have you seen? Could you share with us just briefly so that we get to appreciate, even as we push for acceleration of telemedicine in the developing populations? Over to you, Dr. Avinash. I think you're muted, Dr.
Hello.
Oh, yeah. Now good.
I'm audible.
Yes.
Yes. Good morning to the Finnish Society members. And I have been associated with the Finnish Society for the last 1 year. But I came to know about this project through the help of Mr. Abhishek. So I'll be very thankful to him for taking up this project, which is the sole basic purpose of a country to be developed. As we are seeing, all the developed nations are having a good sanitation. So basically, they are having a good health and a good financial state. So India is also trying to develop in that model. And as due to the COVID, we have started this project. And so we are starting the teleconsultancy first project in India, I think. So for the teleconsultancy through the Finnish Society. So a lot of improvement is going on in between. Like the app was refined. Now the app is being more refined, and this as we have the network coverage is very poor. So the network coverage, it was taken into consideration, like the data consuming and everything. And the people was aware. In particular consultations, I'm interacting with the people. I'm making them understand what is the benefit of teleconsultancy, because more of the community where we are starting the project are a labor class of group. So they don't have time for the consultation. So basically the health is being neglected. So in this type of when our people are going and approaching them, they are waiting. And so within 1 to 2 hours, So around 20 people are getting consulted from me and through our project. So they're having an indirect benefit. So basically, I am suggesting from time to time with Mr. Abhishek and Mr. Jivan, who is in our project. So I'm taking the consultation, and I'm in time to time, I'm letting them know what are the difficulties we are facing. So they are also trying to improve in time to time. So I think that we'll progress further, sir. Hello.
Hi, thank you, Dr. Avinash, for that. You've really kicked us started on the right direction.
As our Prime Minister is also taking digitalization, we are also improving in that part.
Absolutely. And I think this is a really good segue into a question that I had for Pamela Bundi, who's the country coordinator of Finish Kenya. Pamela, I had a quick question on how could you, if you could highlight the role of digitalization in enhancing consumer access to financing for sanitation? Love for you to just dig into that question. The other question that I had for you is, what factors would you say influence investment of financial resources for sanitation at the household level? I think these are two things that I would love for you to just respond to. Over to you, Pamela.
Thank you very much. So on the first question on the role of digitization at the household level,
Pamela, I'm so sorry to interrupt you, but we can't hear you. If you could perhaps adjust the mic.
Oh, sorry.
Hello.
Hello. Is this better?
It's slightly better, yes.
Okay. So on the role of digital.
No.
Maybe we can move to the next question as I check on my technology. What could be the issue?
Yeah. Pamela, could I suggest if you could drop a few comments on chat directly for our audience, and then we can hear back from you when your connection is a little better?
Sure. Thank you.
Thank you, Pamela. Quickly then, moving on to Hajra Mukasa, who's the program manager from WASH, from the WASH team, again from AMREF Health Africa. She's, I believe, they're based in Uganda. Dr. George, I know you had a bunch of questions, so I'm going to hand it back over to you.
Yes, so thank you, Vinci. Actually, what I want us to do is to pick the question that came from our colleague in this session, and our colleague was asking, Angela, if you can hear me, because I want to quickly to summarize the question. The question around what levels of coverage should we have in informal settlements. I know you've worked in Kawempe, informal settlement in Kampala for many years. So if we could just benefit from your reflections on this. And then what do you think? I mean, whether the relationship between sanitation coverage in informal settlements affects health outcomes, and whether that relationship is linear or is much more complex. You can also share that with us a little bit. And the minimum levels of coverage that we should consider for us to significantly realize also significant health outcomes in an informal settlement. Angela, if you can hear me. Hi, Angela. I'm not sure that. Hajira, are you muted?
Dr. George, since we may not be hearing back from Hajra soon, I'm just wondering, I know Joydeep wanted to jump on this question. Joydeep, this is your moment. Before Joydeep speaks, I just want to share a little bit of his background. He's a partner at PwC, the Global Health Insurance Leader. Joydeep, over to you just to get your insights on this process. I know, please react to this question.
Yes.
Thank you, Vinci, and thank you, Dr. George. Yes, definitely, I'm probably one of the, if not the earliest believer in linking sanitation and lowering of the cost of healthcare way back in 2008. That's when the first the kernels of Finnish got founded along with the Finnish team. And that's why I got involved and became program board manager for many years. The way I see it from my vantage point is that everywhere in the world, there are certain trends. And in India, Africa, places which are tropical, we might keep believing that the diabetes or heart ailments, etc., are big killers. But in a way, the biggest loss in the entire country's wealth and GDP happens because of infectious diseases, which are waterborne, which transmit quickly, and they may not always kill people, but they definitely lower their productivity, and therefore the whole country and the GDP reduces. So if we try to link the welfare of people who are using better sanitation techniques with the lowering of the cost of healthcare, is definitely not linear. It has got many elements to it. And we've studied this over a decade now. The whole important factor here to understand is that it's not just the infectious disease and sanitation. It's also a lot to do with water and good quality water. So that water actually prepares the body with immunity against many internal accruing diseases, including the whole well-being of the digestive system, well-being of the whole circulatory and vascular system. So it also prevents hospitalization. While you can say that sanitation prevents large-scale primary care, so costs. So if you look at that, the other element here to be understood is if you have to quantify it. Now studies have been done. When I was a CEO of an insurance company, I actually launched a product with a 17% discount to people who actually use the toilets properly, and people not just have toilets, but use the toilets. And that's why Finnish came in useful in auditing that. And then there was a linkage which suggested a 17% discount can be given in the premium, which means you expect a 17% or more sort of reduction in loss ratio with hospitalization. But hospitalization is the other aspect. There has to be generics, usage of generics. Whichever countries do not specify generics and they rely on brand medicine, insurers will not be able to finally calculate the actual lowering of the cost, because that's not branded medicine costs will keep being erratic. And the last thing there is prescription medicine discipline adherence. If there is large scale self-medication, then also one cannot figure out. So actuaries of an insurance company, if they have to calculate, they need these external things to be done. So and telehealth is a useful way to figure it out. And I agree, Dr. Avinash, that's, in fact, India is now very, very, it's awash with, if I can use the word, with a pun, awash with telehealth. More than 100 million people are using telehealth in India today from various providers.
Yes, sir. Yes, sir. There are various apps also through which I am taking consultation, and many doctors are taking. But Finnish society is doing a great thing in rural India. Specifically, we are having this in metropolitan cities. So rural India is not at all prepared to know about this, because we have a large proportion of our community who are uneducated at present.
Yeah, so just what I want to say is that the first health insurance product has already been launched in the Indian market by one insurance company, which we have helped develop, which is based on, which is where the telemedicine consultation is the claim. So it's a one of a kind, kind of a thing which has happened in the world, and I see the whole world's health insurance systems. This doesn't. This could be a very, very good experiment. Yes. Happening across the country. So, and the last thing here is that there needs to be more experimentation. There needs to be a lot more imagination and risk-taking, and it will not happen from either by the non-profit sector alone. It has to have the for-profit sector coming in, industry participation. It also needs a lot of liberalization of regulation with sandboxes, which are happening, but it needs to accelerate. Without that, we will never get there faster.
Thank you, Joydeep, for that. That's so insightful, especially when you talked about, just the liberalization part, the very fact that it needs to be accelerated and scaled up. And I know that both you and Dr. Avinash mentioned about the digital aspect. And I just want Sameer Savarkar to come in here, because I know he has a lot of insight on telemedicine and the applicability of it in middle and low income communities. Sameer, just asking you quickly to react to this and just bring in your insight on this as well. Over to you.
Okay. Thank you, Vincy, and thank you all the speakers earlier. So this, I'll just maybe introduce with one statement about what we do. We work with a mission of enabling access to healthcare, quality and affordable healthcare at the last mile. And we manage this with the help of our managed remote healthcare delivery platform called Remedy. We have the experience of setting up more than 2,600 rural telemedicine centers in the country through various projects. And by mandate, we do work in the rural areas mostly. So given this, I think very pertinent points that Dr. Avinash and Mr. Joydeep have raised. Basically, the infrastructure of both medical and non-medical facilities is very skewed. So are skilled resources towards certain areas. Firstly, we already have shortage of medical manpower in terms of doctors, nurses, everyone. And then we also have further skew because of the rural and urban divide. In addition, almost all the medicine supplies, all the diagnostic labs are also skewed in terms of their presence. And so larger sections of population who are deprived from sanitation are also deprived from access of healthcare. In addition, there are absence of financial mechanisms especially for primary healthcare. And sanitation is the one which actually is going to affect the primary healthcare. And so I have very few instances of insurance agencies actually trying to work and address the problem of the primary care, and that to the, let's say, the OPD kind of services, which can actually solve these issues. So these are some of the prominent problems. And then it creates a lack of continuity in the health records or the population record, or even the even other details like sanitation facilities, even if we need to put together a mechanism for addressing this jointly. Now, I think the project that Abhishek ji had mentioned is very prominent in that sense, because the data from sanitation and data from telemedicine or healthcare is trying to get linked together in those formats where it can perhaps be used to create appropriate models. This health issue in India and other developing countries is very huge. It's actually as big as the largest non-productive debt creator in these areas. India, for example, it's the largest non-productive debt just after the productive debt of agricultural debt in the rural areas. And millions, tens of millions of families go below poverty line just because of their healthcare expenditure. Now, what telemedicine can really do to these areas is it can give the access to healthcare locally. What people need to travel elsewhere otherwise, and leaving their jobs and having additional expenses, etc. All of those can actually be provided locally, giving an easy access. Further, they can be cost effective and time effective. A lot of diagnosis can happen early in the disease cycle, which save a lot of later expenses to it. And then very few people need to go to higher level. Now, one experiment in Nigeria, a country in Africa, with the developing country template and a model, we had just about 1.5% of population which was dealt at a PHC having to go to the tertiary care level at all, because all those could be addressed through telemedicine locally. And that is a huge saving, both for doctor and for patient and for the economy as a whole. Then we have, of course, continuity of data, which means I don't have to do repeated tests every time I go to a new facility, and all that continuity due to digitization becomes accessible to me. And then effective implementation of program for even the governments. It's a very, very important tool to have the data real time available, digitized, which will help efficient implementation of these programs. So I think this, there is no denial at all. And now everyone has really accepted, and it took a pandemic to get to that stage, but everyone has accepted that telemedicine can be far, far more efficient. And I wouldn't say telemedicine, it's a restricted term. Managed healthcare service delivery till the last mile, or even health delivery till last mile, is a very, very important fact and acceptable fact today. I think we all need to come together to build those models and get them to the public health in each of these countries with the help of certain financial mechanisms.
Absolutely, Samir. I couldn't agree with you more. I really like the points that you raised up. And I'm just wondering from our audience if there's any reactions or questions. Joydeep, I know you have two extra points to add, please.
We have a.
Sorry. Yeah, Dr. George.
Oh, sorry. I was saying we have a question from one of our audience colleagues here.
So I just want to add on to just 2 points that Samir said. Very good, very well said. Just quickly, that whatever we do, we must make sure that all planning, all this design, all of that is fine. Then rubber hits the road. When you try to execute, you come across 2 problems. One is awareness, another is resistance. So first, awareness is where, awareness has to be built, and awareness for the fact that there is a linkage has to be built to the carrot and a stick. So if loans are given, the loan interest rates have to be linked to sanitation, and that is where the stick comes in, because the loan lender has a stick. And insurance or any liability product rates can be more conducive to the people if they are adhering to sanitation. So that is the carrot part. So one has to do that. And on the final piece of adoption, people still don't adopt. There is a resistance among people. And that has to be done through several mechanisms, technological mechanisms, as well as building of trust. Trust deficit has to be removed from either governmental action, insurance companies. Nobody trusts. I mean, people at the ground do not trust these institutions, that it is everything is for their benefit. So for that, one has to build platforms for claims, platforms for dispensational medicine, platforms for dispensational advice, which are uniform. Uniformity and transparency will build trust. Otherwise, all this will be in conferences only.
Absolutely.
Yeah, can't agree more with you, Jaydeep. Absolutely.
Yeah. Dr. George, I know you had a question from the crowd. Over to you.
Yes, thank you, Visia. Thank you, colleagues, for that. But I know we also don't have a lot of time. If Pamela can hear us, we have a colleague from Zambia who is asking, who made a reflection on saying there has been challenges with bringing private sector into sanitation. So the experiences have not been very good. But I know Finish has done marvelous work in India and also Africa. Pamela, if you can hear us, the question is, what are the potential pathways and ingredients that has led to success with the experience that I know Finish has had, and also listening to Joydeep and our other colleagues in India? They are sharing the same experiences that we've seen. Pamela, you can hear us? If you can reflect on that for half a second.
Yeah, thank you, Judge. The first thing is a lot of technical assistance, because this is more of like linking private sector and what will normally be considered as a public good and bringing them together in terms of a business. So technical assistance is really key, but also winning these businesses off this technical assistance over time. So you give it, say, a period of 1 year where they get the technical assistance, the support, the hand-holding and coaching, but gradually win the businesses out of it, so they're able now to continue as full private businesses. Thank you.
Dr. George, you're on mute.
No, I wanted to say that, Caroline, if you can connect the colleague who has that question from Zambia with Pamela, I think that would be wonderful, so that we can have a one-on-one interaction. I think this session, we can't finish everything, Vinci. What I'm liking is that we've already generated a conversation, and I believe that we've also connected people. So some of the questions that we might be having and we might not be able to respond now, we encourage that we continue actually having discussions. And so let's
Dr. George. Yeah, we will be connecting with all the participants afterwards, and we'll share some information. But over to you.
Yeah, Vinci, over to you, and then we see whether we can wrap up.
Awesome, awesome. I was just going to ask Jimmy to pull up, but he's already done a fantastic job. As you can see, there are some really great insights that are coming. I think for me, the key takeaway was the fact that a lot of our work it's not just about the business aspect of things, it's also about building trust with the right communities and stakeholders. We need to be working more and building different kinds of stakeholders, as the Finnish model rightly does. We do know from our different panelists that there were certain things that did come up. I'm just trying to see, for me, that's like the key takeaway. Dr. George, what was your key takeaway? And I know we have like 3 minutes perhaps to summarize.
Absolutely, absolutely. Thank you, Vinci. I think I think two things. One is clearly the connection definitely between sanitation and health and the economy. Clearly the fact that we've barely scratched the surface of sanitation, the potential that sanitation has to create livelihoods for our people, and the fact that we have a huge population of unemployed young people who could get into sanitation value chain enterprises. I think that's clear from the conversation today. When I listened to one of our colleagues from India, one of the points that he posited very powerfully is that it's also factual that marginalization, people who do not have access to sanitation also do not have access to healthcare. That's the challenge that we also see. But telemedicine presents a huge opportunity for all of us to generate real-time data. I think that's very powerful, but also to save costs for both the client, the patient, the household, the doctor himself, and the facility, yeah, but also local and national government. I think that's powerful. So telemedicine then is enabling us to bring down the cost of healthcare and therefore making it more accessible, again, to marginalized communities who, again, do not have access to sanitation. That's really powerful. And I really agree again with you, Vinci, that, as posited by another colleague here, awareness is very important, because then we empower communities, we empower people, that's important, with knowledge, which is critical. And finally, that in all these things that we are doing, whether it's about thinking enterprises, thinking private sector into sanitation, bringing communities on board, and also bringing government so that they can journey with us, it is all about trust capital. And we must build it now if we are to succeed. Vince, over to you.
Absolutely, couldn't agree more. Thank you for that summary. Just want to remind our audience that we have a repeat of this session with more Africa colleagues on the 26th of August between 3 to 4 p.m. CEST. Please do join us then. I want to also just thank all of our panelists and speakers for really contributing very strongly to this panel. Another quick reminder from Lauren, she's popped it out on chat where she said that anyone can connect on Finnish Mondial at waste.nl so that they can make the right connections to the speakers if you have any follow-up questions. Again, thank you for your time. We really appreciate the insights that all of our speakers have brought in. And we also thank all of our audience for tuning in and for really asking your very interesting and important questions. Thank you from the Finnish team, from the Waste team. Yeah, Dr. George, anything to quickly add?
No, obviously, just to wish all of us a very good day and looking forward to engaging again on Thursday, but also engaging directly. Let's keep the lines of discussion, conversation open moving forward. And thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you so much.
Thank you. Bye-bye.
Bye.
Thank you, everybody.
Bye-bye. Thanks.
Bye-bye. Bye.
Thank you, everyone. Have a good day and see you all on Thursday.
Thank you. Namaste.
Thank you. Namaste.
Namaste.
Namaste, Dr.
Thank you.
Avinash.
Thank you.